Yes, Mona, you're
Am I
audible.
Okay. We rise every day with the goal to learn something, and today we are going with that satisfaction of gaining knowledge after this webinar. In this note, I wish everyone a wonderful evening and welcome you to the webinar. We have Dr. Shanmugapriya ma'am, Professor and Head of the Department of Biochemistry from Government Thoothukudi Medical College with us. She has done her MBBS in Madurai Medical College and has received her post-graduation at Madras Medical College in Biochemistry. She has been teaching biochemistry and physiology for medical and dental postgraduate aspirants since 2006 and has coached thousands of students for the past 16 years. She has been continuously aspiring students and making them flying in colors. She is the co-author of the book, A Guide for Preparation of All India NEET Examination, Volume 1, 2016-2017. She has been working as the Head Research and Development of Kriya Medical Technologies Private Limited. She has been instrumental in products validation and in new products development, including a unique molecular transport media for SARS-CoV-2 molecular diagnostic kit for Omicron detection and for simultaneous detection of SARS-CoV-2 influenza A and B, RSV, and is currently undergoing training in novel molecular biotechnology techniques at Kriya. She was representing India in International Federation of Clinical Chemistry Task Force for Young Scientists for 3 consecutive terms, 2015 to 2012 to 2015, 2015 to 2018, and 2019 and 2021. She has received the Young Scientist Award twice in the year of 2010 for her work in type 2 diabetes and in the year of 2008 for the work on coronary atherosclerosis. Best oral paper presentation for her work was received for the topic of TCF7L2 variant RS7903146 affects the risk of type 2 diabetes by modulating incretin secretion or action at Asia Pacific Federation of Clinical Biochemists 2013 held at Bali. She is an educator in PrepLadder and online teaching platform. She is also an educator in an academy for NEET PG aspirants. She runs a YouTube channel, Biochemistry Dr. C. Shanmugapriya, in which she uploads conceptual videos on biochemistry and clinical biochemistry. It's a privilege to welcome and have Dr. Shanmugapriya ma'am with us for this session on arterial blood gas analysis. We welcome you, ma'am.
Thank you. Thanks for the lovely introduction. 1 second. Can you see my screen now?
Yes, ma'am. All good, ma'am.
Okay. I won't be able to write. I was trying to connect my iPad, but it's okay. I will try to explain you. Good evening, all of you. So thanks for the lovely introduction. And as mentioned, I will be discussing about arterial blood gas analysis reports interpretation in just an hour. So this is essential for every medical student to know, because for you to manage any critically ill patient, you will have to understand the various parameters that are involved in the report, and you should be able to interpret the report. So I do understand that many of you are apprehensive in looking at these reports, but my aim is at the end of the session, you will be able to appreciate each and every value that is provided in the report, and you'll be able to make a diagnosis. And all that you will have to do is you will have to follow an algorithm that I'm going to tell you now. And this algorithm involves just 6 steps. Okay. So for you to understand all these steps, I've given few examples and we are going to interpret these reports. So starting from this, give your opinion regarding the acid-base status, given that the sample was taken from a person who was hysterical. And even before you start looking at all these values, what is expected in a person who's hysterical? The person hyperventilates. And on hyperventilation, the person washes away carbon dioxide. Carbon dioxide is a source of an acid. The person is getting rid of an acid. So what is expected? You expect alkalosis. And we call this as respiratory alkalosis. So based on history for this patient, we expect respiratory alkalosis. Let's see if you find the same among the values. And before you start looking at these values, let's recollect normal values. Starting from blood pH. Normal blood pH is 7.36 to 7.44. What is a normal PCO2? Take off the 7 and what is remaining is 36. So normal PCO2 is 36 to 44 millimeters of mercury. Normal bicarbonate is 24 milliequivalents per liter. On either side, you have 3. So it is 21 to 27 milliequivalents per liter. So these are the normal values. Based on these normal values, now look at the blood pH. What has happened to it? Normal is still 7.44. Here there is an elevation of pH beyond the normal value. So it is going to be alkalosis. So step number 1 in any ABG report interpretation is you looking at the pH. As I told you, it has to be between 7.36 and 7.44. If it's less than 7.3, so if it is less than 7.36, we know this is acidosis. If it's more than 7.44, it is alkalosis. But at the same time, I want you all to remember that just because a report has got a normal pH between 7.36 and 7.44, it does not mean you can exclude an abnormal acid base, or you cannot exclude an acid base disorder. So normal pH between 7.36 and 7.44 does not exclude an acid-base disorder. Reason is there are so many conditions when you can find a mixed acid-base disorder. For example, a patient can present with metabolic acidosis and metabolic alkalosis. If you're asking for an example, suppose there is a type 2 diabetic individual who has gone out and has eaten, and following that there is GI disturbance and there is vomiting. We know vomiting causes alkalosis, right? Vomiting, a person vomits out acid, it is going to cause metabolic alkalosis. But at the same time, the person is a diabetic individual who's under stress, and stress will cause diabetic ketoacidosis, and ketoacidosis causes metabolic acidosis. So there are so many scenarios where you can have a combination of metabolic acidosis and metabolic alkalosis, in which case the pH alteration will get balanced and that can be a normal pH. So even if you see normal pH in a report, go ahead and look at bicarbonate and PCO2 values. Only when you see these 3 parameters to be normal, normal pH, normal bicarbonate, and normal PCO2, accompanied by a normal anion gap, only then you can exclude an acid-base disorder. Okay, so this is step number 1. Now, step number 2 is to identify whether it's a metabolic disorder or a respiratory disorder. Now, how do we find out whether it's metabolic or respiratory? For which you have to look at bicarbonate and PCO2 values. Okay, I'll give you an example. So first, let's try to understand how to solve it if it's acidosis. Then let's try to understand how to solve it when there is alkalosis. If there is acidosis, I hope you will all agree with me. If I say acidosis can be caused by either a decrease in bicarbonate or an increase in PCO2. If you're asking me why, whenever there is a decline in bicarbonate, bicarbonate is a plasma buffer. That's a major plasma buffer. And if a person misses the major plasma buffer, metabolic acids will accumulate. That is called as metabolic acidosis. Why should high PCO2 cause an acidosis? Because carbon dioxide is a source of an acid. So for any reason, if carbon dioxide accumulates, that causes acidosis. That's called as respiratory acidosis. Now about alkalosis, there are 2 conditions where you can find alkalosis. One is increase in bicarbonate, the other one is decrease in PCO2. If alkalosis is because of high bicarbonate, we call it as metabolic alkalosis. If it's caused by low PCO2, that is respiratory alkalosis. So this is about you finding out what is the primary acid-base disorder. So just with the help of step number 1 and step number 2, you will be able to find out the primary acid-base disorder. For example, in this case, blood pH is 7.55, which is more than 7.44. So this tells you that this is a case of alkalosis. So what are the choices that you can exclude here? This is not respiratory acidosis. It's not metabolic acidosis. To find out whether it's metabolic or respiratory, go ahead and look at bicarbonate. What is a normal bicarbonate value? I said it's between 21 and 27 milliequivalents per liter. In this case, bicarbonate value is low. Do you think a low bicarbonate can account for alkalosis? If low bicarbonate is the cause of acid-base disorder, it should have caused only acidosis. So low bicarbonate is not the cause of acid-base disorder in this case. Now look at PCO2, normal is 40. Here there is low PCO2. Can a decline in PCO2 account for alkalosis? Yes. And what is that called as? That's called as respiratory alkalosis. This we already guessed. Yeah, how did we guess this? Because there is a history which says the person was hysterical. Hysterical individual would have hyperventilated, presenting with respiratory alkalosis. So step number 1, step number 2, you have identified what is the primary acid-base disorder. Okay, I hope it's clear. Now this is the next part. Interpret the ABG report. Blood pH is 7.30. So are people in live stream answering these questions? Can I get connected once? Number 1, step number 2, you have identified. Okay. So if you're watching this as a live session, try to answer this in the live chat box. I can see the live chat box. If you have any doubts, you can ask me. Here the blood pH is 7.30. You know the normal pH is between 7.36 and 7.44. Here it is acidosis. So we have identified that this is a case of acidosis. Now PCO2 between 36 and 44 is normal. Here it is low PCO2. Can low PCO2 account for acidosis? Never, right? If it's low PCO2, it should have caused only alkalosis. Now look at bicarbonate. Normal value is 24. Between 21 and 27 is normal. Here the bicarbonate value is low. Do you think low bicarbonate can account for acidosis? Yes. What is that condition called as? That's called as metabolic acidosis. So we know for sure that this is a case of metabolic acidosis, using which you have excluded choice C and choice D, right? It's not compensated or uncompensated respiratory acidosis. We know it's metabolic acidosis. How will you find out whether it's compensated or uncompensated? So now let's try to go to step number 3. Step number 3 is to find out the compensation. When I say to find out the compensation, you're trying to assess if there is appropriate compensation or no. First, let me tell you the basis of compensation. The basis is whenever there is a disorder, if the primary defect is metabolic, if the primary defect is metabolic, lungs will come for the rescue. And reversely, if the primary defect is in the lung, then kidneys will come for the rescue. Yeah, this is the basis of compensation. To be very specific, if it's a case of metabolic acidosis, you know, there is a decline in pH caused by a decline in bicarbonate, right? Decline in bicarbonate. It should be compensated by lung, by a decline in PCO2. How do you think a decrease in PCO2 can compensate acidosis? Because as I told you, carbon dioxide is a source of an acid. So by any mechanism, if you can get rid of carbon dioxide from your body, you're getting rid of a source of an acid. So that will compensate for the metabolic acidosis. And how do you think lung will be able to do this? Because as we know, in metabolic acidosis, there is an increase in hydrogen ion concentration in the CSF. And that stimulates central chemoreceptors, and that stimulates respiratory center. The person hyperventilates, the person washes away carbon dioxide, and that is why there is a decrease in carbon dioxide whenever there is metabolic acidosis. I hope you would have all learnt about Kussmaul's breathing. Right? Kussmaul's breathing is a feature of metabolic acidosis. Why does that happen? Acidosis compensation is a decline in PCO2 that is made by stimulation of central chemoreceptors. So do you understand that the compensation is always parallel? What do I mean by parallel compensation? If the primary disorder is a decrease in bicarbonate, the compensation will be a decrease in PCO2 and vice versa. Okay. For example, if it's respiratory disorder, say respiratory acidosis, what would have happened to carbon dioxide here? Carbon dioxide concentration increases. Now, this has to be compensated by an increase in bicarbonate. How will there be an increase in bicarbonate? This is purely based on the buffer system that is present in our body. Whenever carbon dioxide accumulates, carbon dioxide reacts with water to form carbonic acid. That carbonic acid dissociates to form H plus and bicarbonate. So for every carbon dioxide that is formed, do you see that there is an equimolar increase in bicarbonate? That is the compensation that is done in the acute phase. Yeah, this is called as acute compensation that is made by just the chemical equilibrium shift. But in due course, kidney will come for the compensation, wherein kidney will start reclaiming more and more bicarbonate. Suppose there is a patient with chronic obstructive lung disease. Yeah, patient of chronic obstructive lung disease, carbon dioxide accumulates, and a compensation for that is an increase in bicarbonate. Okay, so I want you to understand that only in the case of respiratory disorders, there is always an acute compensation and a chronic compensation. Acute compensation is minimal. Yeah, it's a minimal change that happens in bicarbonate values that is purely because of the chemical equilibrium shift. Chronic compensation is done by kidneys. Slowly, kidneys will start reclaiming more and more bicarbonate. So the take-home message related to compensation is there are two take-home messages. One is compensation is always parallel. If the primary defect is an increase, the compensation will also be an increase. If the primary defect is in carbon dioxide, compensation will be in bicarbonate and vice versa. So compensation is always parallel. And only in respiratory disorders, you see an acute compensation and a chronic compensation. Okay, so you have now understood the basis of compensation. Now, how will you calculate compensation? For calculating expected compensation, we have formulae. Let me first tell you the formula for metabolic acidosis, then for metabolic alkalosis, finally about respiratory disorders. So formula for metabolic acidosis. What is metabolic acidosis? A decline in bicarbonate, right? A decrease in pH caused by a decrease in bicarbonate. What should be the compensation? Decrease in PCO2. How much decrease in PCO2 is expected? Expected PCO2 is equal to 1.5 into bicarbonate plus 8. Yeah, the formula is expected PCO2 is equal to 1.5 into bicarbonate plus 8. Okay. Now, what is the formula for metabolic alkalosis? What is metabolic alkalosis? An increase in pH caused by an increase in bicarbonate. What should be the compensation? That should be an increase in PCO2. So what is the expected increase in PCO2? That is expected PCO2 is 0.9 into bicarbonate plus 16. Yeah, I want you all to memorize these formulae because this will help you in identifying a hidden acid-base disorder. So expected PCO2 is 1.5 into bicarbonate plus 8 in metabolic acidosis. In metabolic alkalosis, it is 0.9 into bicarbonate plus 16. Okay. Now, what about respiratory disorders? So before we proceed to respiratory disorders, I want to give you an example. How do we use this formula? Why do we use this formula? Okay, so an example for metabolic acidosis is there is a decrease in pH caused by a decrease in bicarbonate. When instead of the value of bicarbonate being 24, it is only 18. Okay, now can you calculate the PCO2 and can I see the answer? Good evening, Dinakaran. So I will be happy to see answers in the chat box. So bicarbonate is 18. So what will be the expected PCO2? Expected PCO2 is 1.5 into bicarbonate plus 8. So 1.5 into 18 is 27. 27 plus 8 is 35. Expected PCO2 is 35 millimeters of mercury. Now, what if the report, in the report, it says that the expected PCO2 is still 40. You know, the normal value is 40. Good evening, Gopi. So if the PCO2 happens to be 40, it means it is uncompensated. It has failed to decrease. So it is uncompensated metabolic acidosis. What if the actual PCO2 happens to be 35? It is equal to the expected value, which means this is compensated metabolic acidosis. Now, what if the actual PCO2 is less than the expected value? If the actual PCO2 is even less, 30 millimeters of mercury, then what is your inference? It is never overcompensated. Yeah, your body tries to compensate. When it tries, it either succeeds or it fails. It never overcompensates. So if you see the actual PCO2 to be much less than the expected value, it means there is a hidden acid-base disorder which has caused a further decrease in PCO2. So which hidden acid-base disorder can cause a further decrease in PCO2? When will you wash away carbon dioxide? Respiratory alkalosis. So this is a case of a mixed acid-base disorder wherein you do not only see metabolic acidosis, you also see respiratory alkalosis. Okay. Go PJ, good. Yes. The first scenario is uncompensated metabolic acidosis. The second scenario is compensated metabolic acidosis. And the third one is a mixed acid-base disorder with metabolic acidosis and respiratory alkalosis. So this is how you find out hidden acid-base disorders. And that is why memorizing these formulae is important. Okay. Now for respiratory disorders, I want you to remember a 2x2 table. Yeah, to calculate compensation respiratory disorders, remember a 2x2 table. The first row, or I'll tell you the first column, it is 1, 2, 4, and 5. Have a look at this. This is the table that I want you to remember. 1, 2, 4, and 5. Instead of 4, remember 3.5. Okay. The first column values are less. So the first column is acute compensation. The next column is chronic compensation. The first row is for respiratory acidosis. The next row is for respiratory alkalosis. So this is the tabular column that you should all have in memory. I'll help you understand this. So what does this tabular column mean? Let's take respiratory acidosis. So in respiratory acidosis, for every 10 millimeter of mercury, listen to this, for every 10 millimeter of mercury increase in PCO2, bicarbonate value will be elevated by 1 milliequivalents per liter in acute conditions. The same disorder, respiratory acidosis, if it's a chronic condition, for every 10 millimeter of mercury increase in PCO2, bicarbonate value will be elevated by 3.5 milliequivalents per liter. Now, for respiratory alkalosis, for every 10 millimeter of mercury decrease in PCO2, in acute conditions, what will happen to bicarbonate? Bicarbonate value will be decreased by 2 milliequivalents per liter. In chronic conditions, it will be decreased by 5 milliequivalents per liter. Yeah, so this is how you calculate compensation. Let me give you an example. The same example, a patient of chronic obstructive lung disease with a PCO2 of 60 millimeters of mercury. What is the actual PCO2? 40 millimeters of mercury. From 40, it has increased to 60. Yeah, what is the expected bicarbonate? The expected bicarbonate is, it is chronic condition and 2/10 have increased. From 40, it is 60. So 2/10. And for every 10, I said there is an increase in 3.5 milliequivalents per liter of bicarbonate. For 20 increase, it should be increased by 7 milliequivalents per liter. So instead of bicarbonate value being 24, which is normal, 24 plus 7 will be 31 milliequivalents per liter is what is expected in a chronic respiratory acidosis. Got it? So what is the expected bicarbonate in this case? In this case, it is 31 milliequivalents per liter. Now, what if the patient's report? Yeah, if the patient's report shows you a value of just 24. From 24, it should have increased to 31. Here, it still remains 24. It means it is uncompensated chronic respiratory acidosis. What if the value is 31? It is compensated chronic respiratory acidosis. What if the bicarbonate is more higher? Yeah, even higher than 31. Suppose the bicarbonate value happens to be 35. Yeah, can you call it as overcompensation? No. There is a mixed acid-base disorder. There is another acid-base disorder which is causing a further increase in bicarbonate, which is metabolic alkalosis. So this is chronic respiratory acidosis with metabolic alkalosis. So that is the significance of. Very good, Rohini. I'm happy that you're answering it right. Yes. So what is the final inference here? In this case, if it's more than 31, then your answer will be chronic respiratory acidosis with metabolic alkalosis. So that is all about step number 3. So we are done with step number 1, wherein we look at pH, find out whether it's acidosis or alkalosis. We are done with step number 2, when you try to identify whether it is a respiratory or metabolic condition. Step number 3 is you calculate compensation and find out hidden acid-base disorders. Okay. So tell me the answer here. Blood pH is 7.3. So it is acidosis. Bicarbonate value is low. So we know it is metabolic acidosis. And for metabolic acidosis, what is the expected PCO2? 1.5 into bicarbonate. So 1.5 into 14 is 21 plus 8 is 29. Expected PCO2 is 29 and the value that you find here is also 29, which means it is compensated metabolic acidosis. Got it? This is compensated metabolic acidosis. This is how you find out if there is a hidden acid-base disorder or not. Okay. Now, the next part, I'm going to tell you when will you proceed to step number 4. Okay. So interpret the ABG report. Blood pH happens to be 7.3. Normal is 7.36. The lower range is 7.36. So this is acidosis. Look at PCO2. It is 29. There is a decrease in PCO2. A decrease in PCO2 will not cause acidosis. So this is not a respiratory condition. Look at bicarbonate. Instead of it being 24, it is only 14. So there is a decrease in bicarbonate which has caused acidosis. So it is metabolic acidosis. So till now, you have identified that's a case of metabolic acidosis, but you will not be able to exclude any of these choices because all these 4 choices have metabolic acidosis. Right? So what is the next step? Step number 3 is to calculate compensation. Compensation is 1.5 into bicarbonate. 1.5 into 14 is 21 plus 8 is 29. So PCO2 expected value is 29. What you have observed is also 29. So this is compensated metabolic acidosis. Based on this inference, can you exclude any choices? It is compensated metabolic acidosis. So you can exclude uncompensated conditions, right? B and D can be excluded. Okay. Now to find out whether it is increased anion gap or normal anion gap metabolic acidosis, you should proceed to step number 4. So I want all of you to remember that you can stop with the 3 steps. Yeah, you can stop with the 3 steps if it's a condition other than metabolic acidosis. Only when your diagnosis is metabolic acidosis, you should proceed to step number 4. So when will you calculate anion gap? Please don't sit and calculate anion gap just because you remember the formula for anion gap in the case of metabolic alkalosis or respiratory acidosis or respiratory alkalosis. When are you going to calculate anion gap? Only when it is a case of metabolic acidosis. Okay. Now, what is the basis of anion gap? It's very simple. I'm going to now help you understand the basis of the formula for anion gap and how are we going to use the anion gap value to identify the cause of metabolic acidosis. Okay, so the basis here is in any physiological solution, be it serum or urine or CSF or pleural fluid, in any physiological solution, sum of cation will be equal to sum of anion. Okay, now what are the cations of your plasma? Because we are going to calculate plasma anion gap. What are the cations of plasma? You have sodium, right? That's a major cation. When compared to 135 of sodium, you can consider 3.5 of potassium as negligible. So I'm not going to include potassium in the formula. Please remember in the formula for anion gap, it is not mandatory that you include potassium value. So sodium is the major cation. Apart from sodium, I'm going to call every other cation as unmeasured cations. Okay. Now, what are the anions of plasma? We have chloride, we have bicarbonate. So apart from chloride and bicarbonate, I'm going to call every other anion as unmeasured anion. We know both are equal. Now, what is the definition for anion gap? Anion gap is defined as a difference between unmeasured cation. No, it's defined as a difference between unmeasured anion and unmeasured cation. Okay, so anion gap is defined as a difference between unmeasured anion and unmeasured cations. You just rearrange it. If you rearrange it, you will get the formula as sodium minus within brackets chloride and bicarbonate. So what is the formula for anion gap? The formula for anion gap is sodium minus within brackets chloride and bicarbonate. Now, what are we going to use this value for? To identify the cause of metabolic acidosis. Because we know metabolic acidosis is a decrease in pH caused by a decrease in bicarbonate. But what are the probable causes of decrease in bicarbonate? There are just two causes. One is increased utilization of bicarbonate. The other one is loss of bicarbonate. Don't you think this is logical? If there is a decrease in plasma bicarbonate in your blood, it is either because your bicarbonate has been used up or you have lost bicarbonate. Okay. So when will you be using bicarbonate? Whenever an abnormal metabolic acid is getting generated in your body. Because whatever may be the acid, the acid will be written as HA. This HA immediately reacts with bicarbonate that is present in the plasma to give rise to H2CO3 and A minus. Isn't that logical? Any acid which gets generated in your body, HA reacts with bicarbonate in plasma to form H2CO3 and A minus. So here, there is a bicarbonate that is getting used. And for every mole of bicarbonate that is getting used, A minus is getting generated. What is A minus? That is an unmeasured anion. So in the formula for anion gap, which is unmeasured anion minus unmeasured cation, whenever abnormal acid is getting produced, unmeasured anion concentration increases. So anion gap will be elevated. So the take-home message here is whenever anion gap is high in your patient, it's a clue that is given to you that in this patient, metabolic acidosis is caused by the production of an abnormal acid. The abnormal acid can be lactic acid. It can be acetoacetic acid, which is a ketone body. It can be uric acid. It can be salicylic acid. So any abnormal acid, even any alcohol poisoning. Anybody who's in the chat box, good evening, Kaushik. Anybody who's in the chat box, can you tell me any alcohol which gets metabolized in your body, what will be the product? Suppose a person consumes ethanol. Ethanol gets metabolized by alcohol dehydrogenase to form acetaldehyde. That is acted upon by aldehyde dehydrogenase to form acetic acid. So any alcohol poisoning, it can be ethanol poisoning, methanol poisoning, or ethylene glycol poisoning. In the presence of any of these alcohols, there is going to be an abnormal acid that is getting generated. And these acids will dissociate to form an abnormal anion. So anion gap will be elevated. Okay, so do you still think you need a mnemonic to remember what are the causes of increased anion gap metabolic acidosis? You don't need, because you know what it means. So what is the cause of increased anion gap metabolic acidosis? It's production of an abnormal acid. So what are the abnormal acids that you can expect to be accumulated in your body? It can be lactic acid, it can be uric acid, it can be apart from lactic acid, uric acid, it can be phosphoric acid, which accumulates in a patient with chronic kidney disease. Or it can be ketone bodies, acetoacetic acid, beta hydroxybutyric acid. Or it can be ethanol poisoning, methanol poisoning, or ethylene glycol poisoning. So these are the causes of increased anion gap metabolic acidosis. Now, what if it is because of loss of bicarbonate? There are two routes through which you can lose your bicarbonate. One is GIT, the other one is kidney. There is no other way by which you can lose your bicarbonate. One is through GIT, the other one is kidney. Example for GI loss of bicarbonate is diarrhea. So in diarrhea, when the intestinal mucus is getting lost, because mucus is rich in bicarbonate, you're losing bicarbonate, and that causes metabolic acidosis. So all of you, please remember, vomiting causes metabolic alkalosis. Diarrhea causes metabolic acidosis because bicarbonate is getting lost. Right? An example for renal loss of bicarbonate is proximal renal tubular acidosis, wherein PCT has failed to reclaim any bicarbonate. So if PCT does not reclaim bicarbonate, all bicarbonate will be lost in urine. That causes metabolic acidosis. Whatever may be the root of loss of bicarbonate, whenever bicarbonate is getting lost, your body will compensate by reclaiming chloride. So GI loss of bicarbonate or urinary loss of bicarbonate, your body will compensate by reclaiming chloride. So in all these individuals, chloride concentration is higher. And that is why that is why this condition, these two conditions will be called as hyperchloremic metabolic acidosis. So in your textbook, you can read any medicine textbook or any biochemistry textbook. Okay, there will be a condition called as hyperchloremic metabolic acidosis. What does it mean? It means in this patient, metabolic acidosis is caused by the loss of bicarbonate either through GIT or through kidney. Okay, now in either case, what will happen to anion gap? Anion gap is calculated as sodium minus within brackets chloride and bicarbonate. And in these cases, there is a decrease in bicarbonate. You're losing bicarbonate, but that is compensated by an increase in chloride. So decrease is compensated by an increase. Both will get nullified and anion gap will be normal. So what is your inference? Your inference is you're going to calculate anion gap only in a patient of metabolic acidosis. And what will you use this anion gap for? You try to find out whether it is increased anion gap metabolic acidosis or normal anion gap metabolic acidosis. If it is increased anion gap metabolic acidosis, you should find out the source of an abnormal acid. Source of an abnormal acid can be what? It can be lactic acid, it can be uric acid, it can be acetoacetic acid, beta hydroxybutyric acid, methanol poisoning, ethanol poisoning, ethylene glycol poisoning, or chronic kidney disease. Okay, now what if the anion gap happens to be normal? If it's normal or if it's hyperchloremic metabolic acidosis, it is telling you. Okay, so good evening, Aspire. Very good, Cam 08. Good. If it's normal anion gap metabolic acidosis, it means it's a GI loss of bicarbonate or urinary loss of bicarbonate. Okay, so when will GI loss of bicarbonate be observed? It is either diarrhea or it is renal tubular acidosis, type 1, type 2, or type 4. Okay, so can you answer this question now? pH is low, so it is acidosis. Bicarbonate is low, so it is metabolic acidosis. It is a compensated metabolic acidosis because expected PCO2 is equal to actual PCO2, right? And then you start calculating anion gap. Anion gap is sodium 130 minus within brackets chloride and bicarbonate. So 130 minus 90 plus 14, which is 130 minus 104, which is 26. Normal anion gap is 12. Yeah, normal anion gap is 12 plus or minus 2. Here it is 26. So it is a case of increased anion gap metabolic acidosis, which is compensated. Okay, which means what should you find out? You should find out what is the source of an acid. Source of a metabolic acid is what you should try to find out. Okay. So I hope it's clear so far. So this will be the last part, because I'm not going to get into delta-delta ratio. If there is anybody who wants to know about delta-delta ratio, I want you to raise your hand either on the Zoom link or in the live chat. Okay. So why is this important? Yeah, this is not a cooked up value. This is a report which we got in our laboratory. pH is 7.411. So is it normal or abnormal? Normal value is 7.36 to 7.44. Here it is normal. But what did I tell you? Normal pH does not exclude an acid-base disorder. So you should look at bicarbonate and PCO2. Look at PCO2. Normal value is 40. In this case, it is low. So it is abnormal. Look at bicarbonate. Do you see two bicarbonate values here? One is C bicarbonate P, which is nothing but calculated bicarbonate that is present in plasma. So why do you have a prefix C, or why do you call it as calculated? It is because none of your ABG analyzers measure bicarbonate directly. They measure only pH. They measure PCO2. Based on pH and PCO2 values, using Henderson-Hasselbalch equation, bicarbonate values calculated. That is why the prefix C. But what is the difference between calculated bicarbonate P and calculated bicarbonate standard? Standard means what is the expected bicarbonate of a person when the given blood sample is equilibrated to have normal PO2 and normal PCO2. Do you understand this? What is standard? Standard means what will be the expected bicarbonate when the given blood sample is calibrated to have normal PO2 and normal PCO2. Or in other words, if I ventilate the patient properly, what will be the bicarbonate? Why are we trying to find out? You do that because after you ventilate the patient, after you ventilate the patient, if the bicarbonate value still happens to be low, it means there is a metabolic condition. Okay, but after you ventilate the patient, if bicarbonate value happens to become normal, then it is a respiratory condition. Do you understand the significance of standard value? So why do you find out standard? Once you find out standard value, you try to compare the plasma bicarbonate value, which is calculated, and the standard bicarbonate value, which is also calculated. If both these are similar, it means even if I ventilate the patient, the bicarbonate value is not going to get altered. It means the person is not suffering from a respiratory disorder. The person has got a metabolic disorder. When will you say so? Only when you see that even after I ventilate the patient, the bicarbonate value happens to be the same. For example, if you look at this case, calculated bicarbonate plasma happens to be 7.5. Standard happens to be 20.1. Which means when I ventilate the patient, the bicarbonate value is coming towards normal. Do you understand this? The bicarbonate value is coming towards normal, which means the patient has got respiratory disorder. But has it become normal? It has not become normal. It is still less than the normal value 24, which means there is also a metabolic condition. Do you understand this? Even if I ventilate the patient, the bicarbonate value is not becoming normal, but it is going towards normal, which means there is a respiratory disorder. But because it has not become normal, it's not entirely a respiratory disorder. That's also a metabolic disorder. That is the inference that I would get when I compare plasma bicarbonate value and standard bicarbonate value. Okay. Now, standard is under normal conditions, in the sense normal conditions of PO2 and PCO2. Okay. What was I telling you? So there is a normal pH. This normal pH is accompanied by low PCO2 and low bicarbonate. Now, what are the possible scenarios? Low PCO2 means it can be respiratory alkalosis with metabolic acidosis. Right? One possibility is it is respiratory alkalosis with metabolic acidosis, or vice versa. It can even be a metabolic acidotic condition, right? It can even be a metabolic acidotic condition with respiratory compensation. So how will you find out exactly what is the case? Is it metabolic acidosis or is it respiratory alkalosis, which is the primary acid-base disorder? To differentiate the two, you look at base excess. Normally base excess is expected to be between -2 and +2. And if base excess is too much towards the negative side, it means the person does not have any base. If it's too much towards the negative side, it means the person does not have any base. It means a primary acid-base disorder is an acidotic condition. So between the two examples that I've given you, which is the acidotic condition? Choice A is the acidotic condition. So we know by looking at base excess that this is metabolic acidosis with respiratory compensation. Do you understand this? Now, because it is metabolic acidosis, I want you to go and calculate anion gap. So how will you calculate anion gap? Anion gap is sodium minus, within brackets, chloride and bicarbonate. So 138 minus 109 plus 17.5. So 138 minus 127, which is 11. Right? Anion gap in this case is 11, which is normal. So we know that this is a case of normal anion gap metabolic acidosis. Based on this, will you be able to exclude any of these choices? Yes, I can exclude lactic acidosis because I told you lactic acidosis is an increased anion gap metabolic acidotic condition. But how will you find out whether it is diarrhea or is it renal tubular acidosis? So after you find out that this is a case of normal anion gap metabolic acidosis, to find out whether there is a GI loss of bicarbonate or urinary loss of bicarbonate, you will have to calculate urinary anion gap. So what is the significance of plasma anion gap? It is to find out the cause of metabolic acidosis, to find out whether it is increased anion gap metabolic acidosis or normal anion gap metabolic acidosis. What is the use of urinary anion gap? That is to find out the cause of normal anion gap metabolic acidosis, whether it is GI loss or urinary loss. And what is the basis of anion gap anywhere? In any solution, sum of cation is equal to sum of anion. And for plasma, I said you should include only sodium. I said you can exclude potassium. But that exclusion cannot be done when it is urine, because in urine, there is significant concentration of potassium. So for urine, cation will be sodium plus potassium plus unmeasured cation. Anions, for plasma, I said chloride and bicarbonate. But for urine, you're not supposed to include bicarbonate. Do you understand this? For urine, you're not supposed to include bicarbonate because your proximal convoluted tubule will reclaim every bicarbonate back into circulation. So urinary bicarbonate virtually zero. So for urine, it is only chloride. Chloride plus unmeasured anion. Both are equal. What is the formula for anion gap? What is the definition for anion gap? Unmeasured anion minus unmeasured cation. So if you rearrange this, you will get it as sodium plus potassium minus chloride. So don't get confused here. For plasma anion gap, it is sodium minus within brackets chloride and bicarbonate. For urinary anion gap, it is sodium plus potassium minus chloride. Okay, so how are we going to use this? I'm going to give you a shortcut. If urinary anion gap is negative, do you see a gut in negative? Yeah. If urinary anion gap is negative, it is a gut loss of bicarbonate. Yeah. If urinary anion gap is negative, it is a gut loss of bicarbonate or it is diarrhea. If urinary anion gap is positive, it is renal tubular acidosis. Got it? So based on this, can we calculate anion gap here? What is anion gap here? Sodium plus potassium. 20 plus 5.6 is 25.6. Minus chloride is 22, which is 3.6, which is positive. If urinary anion gap is positive, what have you excluded? You have excluded diarrhea. Okay. Now, is it distal renal tubular acidosis or is it proximal renal tubular acidosis? To differentiate the two, just check urinary pH. Because distal renal tubular acidosis is a defect of acidification of urine, which means in spite of the blood pH being acidic, urinary pH will not fall less than 6. Yeah, in spite of blood pH being acidic, if urinary pH has not fallen less than 6, then what is your inference? It's the defect of acidification of urine, which is distal renal tubular acidosis. So now do you understand the significance of an arterial blood gas analysis report? Yeah. So arterial blood gas analysis report will help you to find out what is the cause of acid-base disorder, even if you know nothing about the patient. You don't even have to know the age. You don't have to know what the patient is suffering from. What is the background? Just look at these values. You will be able to arrive at a conclusion. This probably could be a case of distal renal tubular acidosis. Okay. So that is the significance of biochemistry. Okay, so the main reason behind me having such sessions for undergraduates and for postgraduates is for you to understand that biochemistry is not a preclinical subject. I mean to say biochemistry is not just a preclinical subject. For you to be able to manage any patient, you should have a strong conceptual understanding of biochemistry. Okay, because most of the diagnosis is based on the laboratory values, and most of the laboratory investigations that are done is biochemical. Okay, so do not think of biochemistry as just a first year subject. Learn biochemistry conceptually and continue applying the subject forever. So to summarize the session, there are a few steps which I've told you, which you'll have to follow to understand the cause of acid-base disorder. Step number 1 is check pH. Step number 2 is check bicarbonate and PCO2 to find out the primary acid-base disorder. Step number 3 is calculate compensation to find out if there is a hidden acid-base disorder. Step number 4 is go ahead and calculate anion gap if it's a case of metabolic acidosis. If anion gap is high, you have to find out what is the source of metabolic acid. If anion gap is normal, it is either GI loss of bicarbonate or urinary loss of bicarbonate. Okay. If it is normal urinary anion gap, then go ahead to the next step and if there is normal plasma anion gap, then go ahead and calculate urinary anion gap. If urinary anion gap is negative, it is GI loss of bicarbonate. If urinary anion gap is positive, it is renal loss of bicarbonate. Okay. So that's all about interpreting an ABG report. I hope it is clear. Thank you.
Thank you very much, ma'am, for nourishing ourselves with the facts and knowledge of Ajala blood gas analysis. We thank all the listeners. We thank CHAM team for this great opportunity for learning. And thank you for providing us this wonderful opportunity to connect with Dr. Shanmugapriya, ma'am. I thank everyone once again and hope we meet everyone in future events of CHAM. This is Mona signing off. Thank you, everyone.
Thank you.
Thanks a lot, ma'am. It's very informative. I just wanted to also mention if any of the viewers would have any doubts to be clarified.